So we'll look at a brief introduction. We'll look at some definitions and key concepts. We'll also look at major health data sources. We'll also look at health data communication in Ghana, some policy and regulatory framework, challenges in health data communication in Ghana. We'll also look at some innovations and interventions, and also look at the impact of health data communication on the health service delivery in Ghana, and then look at future directions. It is said that in the age of information, the speed at which data is communicated determines the power of decisions. In today's digital and data-driven world, we all know that timely access to accurate information is very, very critical. This quote is re-emphasizing that speed of data communication is not just a technical advantage, but rather is a strategic power. We know that the faster data is transmitted, the quicker and more informed decisions can be made. If you take, for example, within the public health context, we know that rapid transmission of disease surveillance data can lead to a faster outbreak response. In a similar veins, delays in data sharing can also result in misinformed policies or ineffective resource allocation. So it is important that data is transmitted in a way that will impact decision within the healthcare domain. Health data communication is vital for public health planning and monitoring. In Ghana, we have various platforms and strategies that are used to share health data with stakeholders. However, effective communication can help improve health outcomes, transparency, and also influence policy decisions. When you take low and middle income countries like Ghana, robust health data communication systems are essential for addressing disparities in healthcare delivery, responding to public health emergencies, and also achieving national and global health targets like the universal health coverage and then the sustainable development goals. Within data communication, it is important for us to look at some definitions and concepts. What health data is against health information. Health data simply refers to the raw, unprocessed facts and figures related to a person's health, including the clinical measurement, for example, the blood pressure measurement, lab result, etc., demographic information, and also service utilization statistics. Whilst health information is a product of the processing of health data into a meaningful format that support decision-making, policy formulation, and service delivery. So we know that aggregating immunization data, for example, from multiple sources can lead into reports that shows national coverage trends and transform data into usable information. So what is health data communication? It involves the transmission of data between different actors, such as the facilities, the providers, and agencies using various tools and channels, both digital and non-digital. It also encompasses formal reporting system, real-time data, digital alerts, or manual sharing through paper-based referrals. Whilst health data exchange refers more specifically to the standardized and often automated transmission of health information between electronic systems, such as from a hospital EMR system to a national health database. So while communication can be informal and ad hoc, exchange tends to be structured, system-driven, and governed by interoperability standard. Once I mention interoperability, it's important that we also briefly look at what interoperability is. It is simply the capacity of different health information systems, applications, and devices to connect, exchange, and use data seamlessly across organizational and geographic boundaries. And it includes technical data transmission, format compatibility, alignment.
Subscription. I found this hidden AI that does everything I want for a one-time cost. I'll show you.
Let's say you want to create a coloring book. All you do is type your idea, like, I want a coloring book of cute animals. And just like that, the pages are done for.
And health information exchange. Health information systems are integrated platforms that collect, store, manage, and transmit a wide range of health data. A typical example is the DIMS2 that we use, the District Health Information Management System. The EMR systems are digital versions of paper charts in clinical settings. They contain patients' medical histories, diagnoses, treatment plans, and test results, enabling continuity of care. A typical example is the lightweight health information management systems that we use in our various health facilities. Then with the health information exchange, we are talking about the electronic movement of health-related information among organizations according to nationally recognized standards. We have some major health data sources. The DIMS is one of them that we can obtain clinical data and other service data in the country. We also have Ghana demographic data set. Yeah.
Doc, I think we are losing you. Tech team, is it from my end or there's a challenge with Doc's internet?
Yes, I think we are having a challenge with Doctor's internet.
Okay, okay.
Right. So I think he would have to join back. But in the meantime, I want to inform all participants that we are streaming live on YouTube. So at any point in time, you can go back to YouTube and have a playback of the entire section from the beginning to the end. So let's all take note. You'll be having recorded version. You'll be having your slides, but then you can always go back to YouTube and have a full playback of what is happening live today. And the registration form will be shared during the course of the session. So let's keep calm. The one in charge of the registration link we'll certainly share it in the chat section. So let's give him some time. The registration link will come so we can register. Yes, as I indicated earlier, the facilitator is currently off the call. So we are trying our possible best to get him back on call. So let's exercise some patience. Yeah, Doc, welcome back.
All right.
You can now unmute and continue.
All right. Sorry for the disruption. So I was talking about some key health data communication channels that we have. So some of them are the DIMS, which is a web-based platforms used nationwide. And we are all aware that this platform collects and aggregates routine health service data from facilities. We also have the LIMS, which is a lightweight health information management system used in some public health facilities. And these facilitate internal data flow in hospitals. We also have the Ghana Integrated Logistics Management Information Systems, which tracks logistics and supply chains, which ensures availability of essential medicines. We also have some mHealth apps, like the mClinic, mReach, which are mobile platforms used by CHIPS workers to improve maternal health data reporting and referrals. Within health data communication channels, we have some agencies, and their roles are very, very important in this data communication role. You take the Ministry of Health, for example, they provide the policy direction and coordination of health information systems across sectors. And there we have the Ghana Health Service, which oversees the implementation at the operational level. Then we have the GHIMA, which is also under the Ghana Health Service, which plays a key role in data collection, analysis, and provides some system support. We have the private partners like the software developers. You can also talk about the international donors like the USAID, WHO, German Agency for International Cooperation. They all contribute to system development, capacity building, and piloting of digital innovations. Apart from these platforms that I've mentioned that are used for health data communication, we also have the electronic integrated surveillance, disease surveillance and response platform. We also have logistics management information systems. We also have the district vaccine data management tool, which are all used in health data communication. There are also mobile platforms such as the M-Track and then the ComCare, which are also used for field data collection in specific programs. Most of these systems operate independently, and we know that interoperability remains a challenge, impeding seamless data flow and comprehensive health system analysis. You take the DIS, for example, and the LIMS, the two systems are not interoperable. So therefore, they are working in silos. So these are how the ComCare app looks like, and then the M-Track. They're all mobile platforms that can be used to communicate health data. Integration of health facilities and vertical programs are very key. We know that efforts have been made to integrate vertical health programs like the malaria program, the HIV/AIDS, tuberculosis, maternal and child health into the national information infrastructure. When you take the DIN, for example, it has models that capture data from the National Malaria Control Program, the HIV/AIDS monitoring programs, and then the reproductive health services. So those models are incorporated into the DIMS to collect such data. However, these vertical programs often use separate reporting tools funded by development partners, leading to data duplications and inconsistencies. So integration at the facility level is also uneven. Why? Because even within the same facility, we have other programs also running, which also collect their own data. We can also talk about the district hospital and health centers that are also connected to the DIMS2 and then the EHR system like the LIMS. Many of these facilities in this primary level are the rural areas. Some of them are not even hooked up on the platforms of this nature to be able to facilitate data collection in the digital manner. And once these problems are taking place, it makes it very difficult for one to communicate data effectively. So this fragmentation limits the ability to track patient outcomes across services, coordinate care, and conduct national level analysis for program improvement. Within the landscape of health data communication, there are policy and regulatory framework that must be looked at. The policy and regulatory environment, they play a very critical role in shaping how the health data is collected, managed, communicated, and protected. In Ghana, we have several frameworks that have been developed to guide the implementation of these digital health platforms, and also to ensure the safe and ethical use of health data. So we'll briefly look at some of these regulatory framework. We have the National E-Health Strategy. Ghana launched this e-health strategy some point in 2010 to provide a comprehensive framework for leveraging information and communication technologies to improve healthcare delivery and outcomes. The strategy's vision is to support a well-functioning integrated health information system that enhances evidence-based decision-making, ensure continuity of care, and also ensure that we have health sector accountability. The strategy has this key focus: establishing a national health information architecture promoting the use of EMRs like the LIMS and health information exchange, strengthening interoperability standards, building human resource capacity for health informatics, and also enhancing data governance and security protocols. Despite the strategy's comprehensive design, its implementation has been very, very slow and fragmented, mainly due to inadequate funding, issues of low digital literacy among health workers, and also a lack of coordination between stakeholders. We also have the data protection laws, which is the Data Protection Act 2012 at 843, which also provides the legal framework for protecting personal data, including health data. This law outlines principles for lawful processing of data, right of data subjects, and obligations of data controllers. It mandates the health data be collected for specific legitimate purposes and be protected against unauthorized access or disclosure. The Act also established that established the Data Protection Commission, which is tasked with overseeing compliance and enforcement. But we know that the enforcement of data protection in the health sector has faced some challenges due to limited awareness and weak institutional capacity, especially in the rural areas and low resource settings. There are also guidelines for digital health and health data use. To complement the broader policies, the Ministry of Health and its agencies have also developed operational guidelines for digital health implementation and data use. We can talk about the standard operating procedures for health data reporting through the DIMS tool. You can also talk about the health information exchange architecture guidelines. We can also talk about the digital health for EMRs and mHealth solutions. These guidelines are there to provide standard processes, define data ownership, sharing protocols, and also promote ethical data use across platforms. However, we all know that adherence to these guidelines is inconsistent due to limited regulatory oversight and fragmented donor-driven systems. Apart from these policy and regulatory guidelines, we also have institutional framework like the Ministry of Health ICT for Health Unit, which has the roles and responsibilities of leading digital health policy formulation, monitoring within the Ministry of Health. It is supposed to ensure alignment between the ICT investment and then the health sector priorities, and also liaise with national and international partners on e-health initiatives. We also have the e-health technical working group called the e-health TWG, which is a multi-stakeholder advisory body that provides technical guidance and strategic direction on digital health innovations. They include representatives from the Ministry of Health, the Ghana Health Service, the private sector, development partners, academia, and the civil society. This technical working group plays a vital role in reviewing new digital tools, harmonizing digital platforms, and also supporting the development of interoperability standards. We have our own team, Center for Health Information Management, which is also responsible for health data management and reporting, providing standardization of health indicators and tools, ensuring monitoring and evaluation, provide capacity building and technical assistance, ensure data quality assurance, health information systems governance, and also conduct some research and undertake some publication. There are some challenges in health data communication. We can talk about the technical barriers, which are lack of interoperability. We are all aware that DIMS2, the LIMS, and all other platforms are in siloed. Okay, they are all working independently. As we speak, most facilities will have to compile their data Apart from the links, some of the reports are generated, some will have to be done manually before entered into the DIMS. So there is lack of integration of these systems. Apart from that, we also have limited ICT infrastructure in the rural and remote areas. So you can talk about unreliable electricity power supply, limited internet connectivity, insufficient hardware like the computers, servers, etc. We also have human resource constraints in the area of limited training and digital literacy among healthcare workers. And these are issues of ICT knowledge, inadequacy capacity that we have in the system, digital literacy issues, issues of inadequate training in the LIMS or the DIMS tool or data analysis tools. We also have issues of high staff turnover, limited refresher training, underutilization of available health data for planning and decision making. We also have issues of language and health literacy. So here, mostly communication to patients, especially in diverse local languages, is very, very difficult because we have quite a huge number of local languages that we speak across the country. We also have data quality consent issues, issues of incomplete. Once these platforms, the DIMS, the LIMS, logistics management information system platforms, once they are not linked, it means that some of the reports have to be generated manually and entered into some of these platforms. And it can come with its own adverse errors, etc. There's also delayed reporting. Apart from that, we have privacy and security issues. When you get to the health facility levels, a number of them are lacking protocols for data access control, encryption, issues of how to secure storage and limited enforcement of data protection protocols. So these are issues that face health data communication. We also have organizational issues like poor coordination between the vertical programs. So vertical programs, as I've mentioned earlier, HIV/AIDS, malaria control, TB, maternal health issues, they often use their own data systems, largely driven by donor requirements, and there's little we can do in that area. There's also fragmentation of this. Once we have these programs using their own data platforms, it creates that fragmentation or makes it very difficult for us to have an integrated, coordinated data systems, and makes it cumbersome for policy makers. Additionally, there's also lack of communication between program managers and also facility level staff, which results in inefficiencies and duplicated reporting. We have inconsistent data reporting practices. Here, health facilities, they differ widely in their reporting frequencies, data completeness, adherence to reporting timelines, etc. Some facilities also underreport their data due to lack of trained staff, competing priorities, or logistical constraint, etc. We also have inconsistency that undermines data reliability, and it also hinders efforts to monitor health trends or allocate resources equitably. Within the data communication dimension, we also have some innovations and interventions that we can learn from. We have the mobile health solutions. Here, mobile health technology for community health, which was implemented in the Upper East region, have demonstrated success in using mobile phones to improve maternal and child health data collection. They send reminders for antenatal care and also communication between community health workers and facilities. We also have other mobile-based platforms such as the ComCare and M-Track, which have also been used for real-time data entry, syndromic surveillance management, and also emergency help reporting, especially applied in the underserved areas. We have telemedicine platforms. Ghana Health Service piloted these telemedicine centers in partnership with the Novartis Foundation and Vodafone Ghana, particularly in the Ashanti region and then the northern regions of the country. And these centers have enabled remote consultation and support data sharing between peripheral and urban facilities, thus enhancing access to specialist care while generating electronic records of interactions. Some blockchain applications are also being applied. Some pilot efforts have been investigated. The use of decentralized
Hello, Doc. We've lost your voice. Or it is from my end.
Yeah, I think currently Doc is off the call. So yeah, that's on back. Doc, please unmute and speak.
Yes, okay, thank you. So I was talking about government and donor-supported funded programs aimed to improving data communication. So I was mentioning health informatics project being supported by USAID and CDC, providing technical assistance for DIMS2 scale-up data validation and dashboard development. Currently, when you look at the DIMS2 that a number of us are working with, a lot of things have improved on the DIMS2 platforms, and all have been made possible as a result of funding from agencies. We also have immunization and HIV trackers supported by Gavi and Global Fund, which led to the integration of the immunization and HIV data into the national systems for better tracking and resource allocation. We also have data for decision-making initiative, D4D, supported by the Bill and Melinda Gates Foundation, which also focuses on using analytic tools and dashboards to improve health program planning and service delivery. There are also areas of capacity building initiative for health informatics. For example, the University of Ghana, KNUSC, now offer postgraduate degrees and short courses in health informatics. We also have in-service training programs supported by Ghana Health Service, WHO, and UNICEF that focus on DIMS2 use, data quality audit, and data visualization. The digital health capacity building strategy implemented by Ministry of Health also outlines plans for continuous professional development and accreditation of digital health training models. There are some innovations from other low and middle income countries that we can learn from. You take Rwanda, for example, they have successfully implemented a nationwide health information management systems which is integrated with the community health worker data using mobile platforms, achieving higher reporting compliance and improved maternal health outcomes. You can also talk about the Kenya's Afya Care initiative, which also integrates the EMR systems with national health insurance and diagnostic systems, enhancing service tracking and fraud reduction. India's integrated health information platform also provides real-time surveillance data from both private and public providers through mobile apps and dashboards, leading to an improvement in responsiveness to disease outbreaks. Now, what are the impact of health data communication on our health service delivery? We have an evidence of improved decision-making and planning. You take the DIMS platform, for example, it has become the main platform for aggregating and analyzing facility health service data in Ghana. So here, health managers at the district level, regional, and national levels, they make use of the dashboards and report generated from the DIMS tool to allocate resources. They plan for outreach programs and also assess service coverage. The health data communication also supports performance reviews and annual planning cycles, where data trends guide decisions on infrastructure investments, staffing, and drug supply needs. This, we say, has enhanced accountability and also improved alignment of donor funding with our health priorities. We also have the use of real-time data for disease surveillance and outbreak response. Here, the ability to transmit health data in real time has enhanced Ghana's capacity for disease surveillance and rapid outbreak response. You take, for example, in the heat of COVID-19, the Ghana Health Service, through the integrated disease surveillance and response framework, use mobile and digital platforms to collect real-time information on priority diseases such as the COVID-19, cholera, and Ebola. Some of those apps, you heard about the SurveyNet, the SOMAS, Surveillance Outbreak Response Management Analysis Systems, and then the ArcGIS-based dashboard. So for the health data communication with the COVID, for example, Ghana Health Service was apt communicating with the public. You go on their webpage, the COVID dashboard, you could find all the outbreak cases being analyzed by regions, etc., using the dashboard, ArcGIS-based dashboard. These innovations improve timeliness in detecting and responding to cases, ultimately contributing to effective containment strategies. It has also contributed to maternal and child health services. Here, health data communication has directly benefited the maternal and child health service delivery in Ghana. So platforms like the MOTEC and then the child health records apps have all improved tracking and your data are I wasn't expecting the network. So, so at the facility level, data from the EMR systems like the LIMS, the DIMS2, have also enabled midwives and nurses to monitor maternal and neonatal outcomes more accurately, identify the high-risk pregnancies, and also plan referrals promptly. In the area of monitoring and evaluation, we also have improved health data communication as a result of the various data communication platforms that we have. Routine service data are increasingly being used to track progress on our neonatal health indicators, including those that have been aligned with the health sector medium-term development plan and the sustainable development goals. The digital dashboard developed through the partnership with donors also support M&E units at national and sub-national levels in generating real-time insight into service delivery trends, thereby identify underperforming regions and
The network seems not to be very, very conducive for Doc this afternoon. Yeah, Doc, welcome back.
thank you.
Yes.
Sorry for
The
the
network, your network is not very favorable this afternoon.
very, very bad. Today we had some rain around, so.
Okay, all right.
So there are some key actors in the health data communication, like the Ghana Health Service, the MOH. We also have the healthcare workers, nurses, midwives, medical staff, HI managers and officers, community health workers, IT support staff, and development partners like the WHO and USAID. So what are some of the strategies and interventions that we need to put in place to overcome some of the challenges of health data communication? One, we need to build capacity, train our healthcare workers in the area of digital literacy and data use. So even when you go to the facilities, the challenge of providers making use of data from the DIMS is not optimum. Most of us are still doing the aggregation and displaying the descriptive outcomes of the services we provide. We also need integration and interoperability of our various platforms. So like the LIMS that currently operating at the facility level, we need to integrate this system with the DIMS so that data from the DIMS, the EMR systems like the LIMS can move straight into the DIMS too. We also need infrastructure development by improving our internet access and also providing digital tools in rural facilities. Policy frameworks, implementation of the e-health strategy and data protection acts, education must go.
Yes, the facilitator dropped once again, so let's give him some time to get back. It's very unfortunate we are having network challenges at his end today. Uh, but I'm sure he's going to join back so we can hear from him once again.
Okay, so let me just add that I have once again posted the link to the Allied Health Professions Council survey. We entreat every health information officer to respond to the survey as it is very important for policy at that level. So kindly take note. It's posted in the chat box. If you haven't done that yesterday, please go and then respond to the survey. Thank you very much. Doctor, you are most welcome.
Thank you very much. So the future direction, we need to have a nationwide rollout of interoperable LIMS system. So currently, as we are all aware, the LIMS is just at the facility level. We should be able to link all up and then have data available at any part of the country that we want to go and access care. We also need the integration of community-based data into the national health database systems. Then also enhance policy enforcement for data privacy and standardization. So because we have limited empirical data on system interoperability, there is need to also conduct some studies to see the feasibility of some of these interoperable platforms in order to help us scale up our platforms as well. We also need some future studies to evaluate the effectiveness of these communication tools that we have, like the DIMS2 platforms, the LIM platforms, in order to have some backing data to really embark on a wide scale up of some of these platforms to help data communications. There is also a need to have a region-specific or facility-level assessment. So facility-level data communication workflows, bottlenecks, user experience, even though we have some studies, but we need to specifically tailor some of these studies in order to know the challenges that are faced in these areas so that we can resolve them based on region specific. So my final conclusion is that health data communication is a pillar of Ghana's health system. While we have made significant progress in this area of data communication, there is still issues to address in the area of technical infrastructure, human resources, in order to harness the full potential of data for health improvements. So on that note, I say thank you. And once again, sorry for the interruptions in the network. We hope that next time in the future, we will not rely on the local network again, but rather look for other means like the Starlink for some of these services. Thank you very much. Floor is open for questions and discussions.
Thank you. Thank you very much, Doctor, for this very important presentation. And we are grateful for your patience, despite the fact that the network is not stable, but you have continuously endured to get to this point. So we are grateful. The floor is open now. If you have a question, kindly raise your hand and you will be called on to speak, or you can put your question in the chat box and I'll read it out. So the floor is open. The floor is open. Kindly put forward your question, or if you have any comments or suggestion to make. Okay, so we have Joseph. Joseph, kindly unmute and proceed. Tech team, can you kindly help Mr. Joseph to unmute?
Yeah, Joseph, unmute and speak to us.
Hello.
Yes, we can hear you.
Hi, we can hear you.
Yes. Good afternoon.
Good
So I
afternoon.
want to thank Doc for the presentation. My question and maybe challenge is that if the LIMS and the integration to the DIMS, when the LIMS was implemented at the on the clinical level, we had a lot of challenges and we in communicating data. As of now, the challenges are still there. And we, at my level, I did the polyclinic, we communicated to management. So we found a way of getting, a complete data to the DIMS too. But my question was that the LIMS was started from the hospital level. And maybe all these challenges were there. Why didn't they work on it before getting to the grassroots? And up till now, the challenges are still there. So maybe if there's remarks on that, I'll be happy. Thank you very much.
Okay, thank you very much,
So,
Mr. Joseph. So for now, that's the only question. So Doc can go ahead to respond to that. Thank you.
yeah, thank you very much. I believe at the hospital level and even at the tertiary level, some of us who are here on the platform were part of the implementation, if I am right. Where
Yes,
some of us
Doc, everyone is
from the,
muted, so they may not be able to
uh,
respond. So please proceed.
okay, so the challenge we have in our system, I mean Ghana, when a system is being brought, this system came from somewhere and Ghana decided to buy into it. But when it came to the implementation, most of the providers were not fully involved in the implementation. So a software was bought and dumped on the facilities to implement. So once you can provide some equipment, well, they'll come and then set it up. And then government also provided some support in terms of the equipment and so forth. So there wasn't enough engagement as protocols will require, that you understand your system and look at what must be integrated into or what must be automated. So you realize that the software was brought in, implementation was done, but when it comes to data reporting, that is where we were having much of the challenges. Because at the end of the day, we put in data and we are not able to generate any report out of it. And most of the things will have to be done manually again. So I think the implementation was poorly done. Facilities were not properly engaged. That is how come still we are having these challenges. We will come, implement, the flow will be there, patients will be able to walk through the system. But when it comes to outputs from the system, there's always a problem with that. So that is what we need to really take up as an association and try to see whether we can engage with the 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 planning department of the Ministry of Health so that these things can be quickly resolved and make data generation smoother for the system.
Thank you. Thank you very much, Doc. I think we have another comment. You touch on telemedicine, and it is a
Yes.
pilot in the Ashanti region. Will it be scaled up to the nation? So, Doc, so that's another question in
That
the
is
comment chat.
all right. So that is actually the goal. The goal is to be able to have diverse service provision platform to make healthcare access easy for the population. So once the pilot is successful, why not? The rest is funding so that government can help roll out some of these platforms. Just like we are doing for the LIMS, which facilities are being supported at the initial level to get the system working at the facility level. Then they will now have the national linkage to be able to get the system talk to each other. So I think with time, it will also be scale up to cover the entire country.
Thank you. Thank you very much. Mr. Emmanuel Opoku, your hand is up. Kindly unmute and proceed with your question.
Yeah, thank you
Emmanuel
very much.
Opoku. Yeah.
Yeah, Doc, that was a nice presentation. But I believe health information, we have a bigger challenge. Even the definitions of some indicators The teaching hospitals define it different. Ghana Health Service define it different. For example, a new patient. Ghana Health Service will say a new patient is any patient that visits the hospital for the first time in a particular year. Whilst the teaching hospitals, our definition is that a new patient is a patient that visits the hospital for the first time without using the year. When it comes to, for example, patient days of a particular ward, a teaching hospital will say the patient days from the time the patient was admitted in that particular ward till the time the patient is discharged. Whilst Ghana Health Services, time the patient was admitted in the hospital till the time the patient is discharged. And these definitions are different. So it makes it very even difficult to use the LEMS, because sometimes we, those in the teaching hospital, we are using the LEMS and we find out that the definition and the population it is populating is wrong. I believe as a profession, we should all come together and have one definition. We shouldn't have different definition when you go to the teaching hospitals and different definition when you go to the Ghana Health Service. It is really a worry, and I don't know how we are going to resolve it, or if you have an idea of how best we can resolve this issue. Thank you very much.
Thank you. So these are food for thought for all of us, because now we are becoming a formidable association. So, and we equally have very good intellectuals among us, and we can start looking at some of these SOPs document available at the teaching facility, because they are autonomous. Their way of doing things are a bit different from the Ghana Health Service. So if we don't work together as corporate institutions and put together documents that can harmonize health data generation, we'll always be having all these fragmentations in the system. So it is a wake-up call for the association to also start putting together some team to be looking at some of these policy documents or SOPs, so that we can harmonize all of these documents to make it a one document that can be used by the health sector players under the Ministry of Health.
Thank you. Thank you very much, sir. Anas, before I come to you, someone, I don't know whether you are asking or you are passing a comment that the LIMS uses the teaching hospitals definitions. I'm not sure about that. May you want to throw light on it, David Efiri? Okay, so since we are not hearing from you, name, the floor is open. You can go ahead.
Hold on, hello? David, if you are unmuted, so you can speak.
Okay.
Yeah, like what my colleague said, I was emphasizing on it that when you assess how the report from the LIMS comes, how the report are generated, I think based on the definitions, my brother rightly said that the teaching hospitals own are different from we are in the Ghana Health Service. When I check the report from the statement of outpatient and the report from our bed utilization, you could clearly see that the definitions that my brother said that it is at the teaching hospital, it suits what the report is giving out to me from the LIMS. That is why I said that I think that it's from what she is saying. If you can get me right.
Okay, I get you now. Thank you so much. A lot of concerns with the registration link. Be patient whilst the tech team fix that. And so they are fixing it, and you will soon have it. Thank you very much. Mr. Kwame Sakode, kindly unmute and then proceed.
Yeah, Mr. Sakode, you can unmute him. Yes, we can hear you.
I would want to contribute to the aspect of the telemedicine, the piloting aspect in Ashanti region. I don't know whether the government is doing it or it's an NGO that is doing it. Mostly when the NGOs come in with that, it ends up with the government and it doesn't continue. But this one, I don't know, the aspect went of this thing went up. Whether the government is doing it or it's an NGO, I want him to clarify that part.
Okay, so currently I know a private facility started it, and they are still working with the telemedicine. What the founders are requesting is that the NHI should be able to incorporate some of these telemedicine services into the NHIS list. And then the government can also come on board to help roll out or scale up some of these telemedicine services in the rural areas that do not have the right providers within those areas to be able to access some of the experts also to take care of their medications. So currently it is within private facilities, but I think there's some arrangement with the NHIS that they are taking care of some of the bills coming from that area as well. So government is not deeply involved in the telemedicine project in the Ashanti region.
Thank you. Thank you very much, Doc. Samsung SM, you have a question? I see you making some comments. Mr. Senam, can you unmute Samsung SM A155M? A1555M. Yeah.
Okay, kindly unmute and speak.
Samsung SM A155M, kindly unmute. Okay. So I think let's proceed. We have Mante. Mante, it's your turn. Kindly unmute and proceed with your question.
Yeah, Mante, proceed.
Hello, good afternoon. Yes, this is not a question, but
Hello.
the registration.
Yeah, Mante, kindly hold on. Kindly hold on. I think Samsung is on. So let's take it from him, then we get to you.
Okay.
Yeah, Samsung.
Yes.
Hello.
Go ahead.
Yeah, please, I want to ask if the UCC electoral, what measures are they putting in place to help GHIMA people who want to build capacity on data management without any barrier, comes to pass? Yeah, what measures do they have in place to mobilize people who have interest in capacity building? Yeah.
Okay. Thank you very much. I think that's a very good one.
Yeah.
But Doc, will you want to respond to it now, or we should take those related to the main presentation and later we can discuss this?
Oh, well, we can still take it. I know
Okay.
there are some engagement going on. We want to start from somewhere. UCC HIM department, when it comes to, let's say, preceptor engagement, previously we were doing our own monitoring, and currently we want to engage some of us within the facilities to be able to do this when students come around. So engagement is ongoing, and some people will be identified to play such role when students come on vacation, internship, etc. So from there, we could still engage, and I know talks are ongoing, documents are being reviewed, also through Ally Health to have a harmonized program to train HIM professionals. So I believe we'll get there where various training institutions will engage GHIMA in a number of programs to build capacity of its members.
Okay, thank you very much, Doc. I have an announcement on that. So when we are done with the question and answers, I would make that announcement that is coming from the president relating to the preceptor engagement. So when we are done, I would let that announcement come across to members. So let's continue with the question and answers. So next, I think Monte can now come on. Monte, you're unmuted.
Yes. Good afternoon. Mine is a concern. The registration link, when you click on the registration link, it's asking for access before we can register. I think a lot of people are having the same challenge.
If you would also agree with us,
So if we can rectify that.
This one,
Yeah, so
Yes.
the one in charge just indicated that it has been rectified. So a new link has been shared on the chat area. So please go and then do the registration. It has been rectified. Thank you.
All right. Thank you. And let's proceed to the next one from Bismarck Botchway. Bismarck, kindly unmute and proceed.
Hi, good afternoon, everyone, and thank you very much, sir, for the presentation. Sir,
Thank you.
my question borders around piloting of projects and before they are implemented. I would like to know what really goes into piloting, and then what we see before we say a project has been successfully piloted. From the little I know that LIMS was piloted in the central region. It was supposed to be piloted for a year, but due to COVID-19, the piloting even extended to more than the year before it was rolled over to other facilities in the country. So these problems that we are seeing with data inconsistencies, what we put in, we can't take out. Did they not see what did they see? What happened? And they said it has been successfully piloted before they rolled it over. Because I believe that all these problems that we are talking about could have been seen over there, rectified before the final rollover in the country. So I would like to know what really goes into a successful pilot.
So to really have a successful piloting of a project, you need to have total engagement with the users. Okay, the users will be able to tell you what they do and what they want to see the system you are bringing on board to do for them. I was working in the facility before I moved out. Apparently, the facility bought the harms. The developers came to implement the harms for the facility. Training of the users was inadequate. We couldn't have a facility champion to lead the process when the developers left. So when I came back from school, I re-examined the software, went into the back end, look at what is there, what we are doing, and what needed to be done before we have total rollout. Apparently, when the developer left, people stopped using the software until I came back from school and then started engaging management that, oh, this package, I've gone into it, we can do A, B, C. And management have their priorities. The first thing they said was, okay, we wanted to process our claims electronically because that is where a chunk of the money is. About 80% of the services provided is on credit, which is the NHIS. So if we can process our claims electronically, that is the first step to pick it up for. So upon further assessment of the system, we realized that the developer puts some buttons that you can just turn on and you'll be able to start making use of some of those models at your facility level. Apparently, the developer wanted to have a total control over the management of certain aspects of your system. Like claims, they will have to come and sit in and do all those things. And they're also looking at putting in, how do we call it? Getting jobs for their own people and also have a reliable income at the end of every month. So the long and short of it is that system implementation and piloting must highly involve users. When the users are not involved, the developer can bring anything, implement it, and leave. And at the end of the day, the users will be having the challenges. So for me, I know the LIMS, even at it started with the teaching facilities and some selected hospitals. As we speak currently, they are also having challenges, especially dealing with the report, which is key to our operations, because we deal with the reports. Okay, so if we can't generate simple, basic statement at the end of the day, then it is not worth putting in data. So I would suggest that once all of us are becoming very aware of the kind of thing the LIMS is able to do and so able to do, let's come together. We already have a formidable association, and they should be able to set up some teams to champion some of these things, liaise with the ministry. This whole LIMS implementation is directly under the ministry, not even under the Ghana Health Service. Okay, so it's management decision. If the implementers really want to engage well and know exactly what the facilities are doing and what they need from the DIMS, the LIMS, and also linking up with the DIMS, we should be able to sit at a round table and resolve the issues. I believe some of the developers are still around and scaling up the LIMS in the facilities. They will say, use it. When the problem comes, we'll fix it. But they are never available to help fix the problems. So I think we should be able to engage them so that the basic things that we need a system to do for us, it should be able to do it for us. We don't have to use the system and still turn around and be using manual system to generate reports to submit into the DIMS. So for any successful system to function well, the users must be deeply involved in the engagement process, and then also tailor the system to their needs. And once the system, the users are saying, fine, the system we are using is at the optimum, then we know that we can scale it up in other facilities. We know that we have various levels of care provisions, the primary, secondary, the tertiary. All of them are not doing the same thing, but there are basic things that runs across all the levels. So whatever will work at the primary level will not be the same at the secondary, will not be the same at the tertiary. So we have to look at the needs of the facilities and now tailor what is needed at the various levels so that we can all have an enjoyable work in the course of our day-to-day operation. So I think that is my take on the issues on the links.
Thank you. Thank you very much, Doctor. And I think on this matter, you are very right on point. We all know the circumstances within which LIMS implementation started, and that it started somewhere without limited, and in some cases, no stakeholder engagement when it comes to the implementation. At the regional levels, we were there. All at a sudden, certain months, we didn't see facilities reporting. Then we called to find out. Then they said, oh, some people came and put some system there and said we should stop using our paper base. And then, use those systems. So most regions were not even aware that LIMS were being implemented in their health facilities. And so these are some of the challenges. And so when the facilities started calling the regions did not even know who to contact. You call Ghana Health Service HQ, they said, oh, no, we are not aware. And so LIMS has its own challenges. GHIMA and as an association came in there, we did a thorough assessment and we submitted a comprehensive report which contains very good recommendations to the ministry. But as usual, you know some of the challenges with these things. And so it is something that we still have very keen interest in and will continue to follow up to ensure that, our inputs are heard and that something good will come out of it. LIMS is a very good system, and if it works very well for all of us, it will help us in the management of health information in our various health facilities. Prince, I don't know whether this question is to doctor or it's just a general comment you are making. You're asking whether the institutions are aware that many qualified HIOs remain unemployed while nurses and midwives are already burdened with clinical work and they are expected to handle data-related tasks as chiefs and health facilities or health centers. Yes, the system is aware that we have a lot of qualified health information officers who are not yet employed. And this is something that they are aware of, and the feedback is that they have not been captured in this year's budget. So for this year, employment of HIOs, it won't happen. Maybe subsequently, they may consider that. Okay, is there any other burning issue? For now, there is no any hand. Okay, maybe we can take the last one. Abraham. Yes, in law. Kindly unmute Abraham Ndekudugu. Kindly unmute and then proceed. And this will be our last question. IT team, kindly support Mr. Abraham to unmute.
Yes, Abraham, you can now talk.
Okay.
Yeah.
Good afternoon to everyone.
Good afternoon.
Good afternoon to my former lecturer, Dr. Godwin.
Good afternoon, Abraham.
Yes. Thanks so much for your insightful presentation.
Thank you.
Please, there are some few things that I will want us to look as health information practitioners. One of the things I have realized at the facility level is there are some medical records officers that go through the process and they are able to be converted into health information officers and biostatistics officers. But I bet you it's like the training they undergo
is nothing to write home about. And if they are given position as health information officer to operate, then they disgrace the whole profession. So I beg if we can look into it, and especially the training institutions, how they train them is turning to be something that our management and the whole health sector can look down upon our profession. So if we can look into it, and I was very happy when the doctor mentioned that we can set up a team to look into the future. What are the things we can do in order to promote our profession and ourselves? So I beg, let's look into it and see how best we can empower those people. Otherwise, the effort that we are putting, somebody is also somewhere demeaning us and we don't go anywhere. Thank you so much.
Yeah, thank you. Thank you very much, Abraham. This is a point that is well noted. I mean, we know some of our colleagues who were in the system for a very long time without any form of training, maybe some basic training at the lower level. We know some time ago there were some conversions where they converted them. Yeah, we understand. So once they have been converted, so I think the onus now lie on the employer to ensure they build their capacity to, I mean, reach the level they want them to be. But unfortunately, we know within the system how these continuous professional development programs are handled. Most of the time, they are donor driven. And if the donors are not coming in that area, that ends it. And so we as an association, I think that we need to take up this very, very seriously to ensure we bring up our colleagues who really need to build their capacity. Okay.
There's also a question in the chat.
And yes. And as Doc already mentioned, I mean, there are a lot more that we can do to work with the universities to ensure that some, I mean, very short courses are designed to cater for these needs. I think it will be very, very important. And so we have taken note of that, and I think moving forward, it will be part of our planning activities. Mr. Senna, you are making a point.
No, I wasn't making any point.
Okay.
I think I saw Mr. Dixon Hanyo on.
Yes, I think he dropped. I did indicate that was actually going to be our last question. We have kept up for a very long time. Okay. Is Mr. James Amewuda on the call?
It's quite unfortunate. The president and the general secretary are in a transit, so it'll be difficult for them to join the call.
Okay.
So the president has sent a special announcement to be given to members on call. Let me briefly get to the message. Yeah, so this is a special announcement from the president of GHIMA. This reads that Prof. Nathan of UCC, Department of Health Information Management, is requesting members, that is all of us, GHIMA members, to be in readiness for their interns. It means that this vacation, they will be sending some interns to us at our facility level, district level, at the hospital level during this vacation. It has been an arrangement that Doc already, spoke about. So he's requesting us to be in readiness for these interns that are coming to us. So he's asking us to take very good care of them when they come. So this is a special announcement coming from the president that Prof. Nathan of the UCC department is requesting all members, all GHIMA members, to be in readiness for some intent that will be coming from their school. I mean, the Department of Health Information Management to our institutions, hospitals, health directorates, teaching hospitals, etc. And then they are also requesting that we take very good care of them and then teach them, help them to acquire the knowledge that they are supposed to get on the field. Thank you very much, Honorable Anas. That is special announcement coming in from the president. Thank you.
Thank you. Thank you very much. And on this note, I want to, on behalf of the president and the entire GHIMA fraternity, I want to extend our special thanks to Dr. Godwin Japa for responding to this call, a duty that he has well responded to take us through data communication as part of our CPD series. Doctor, we cannot thank you enough. We know always you are available. You are always giving us a listening ear, and we will still continue to knock on your door because we know there is a lot that you can offer the association in our bid to grow. Thank you very much for your time. Thank you very much for the experiences that you have shared with us. And I believe it will go a long way to, make members change the way they do things in their various health facilities. Thank you very much once again. And at this particular point, I think that if you have other pressing issues, you can go off whilst we discuss other matters with members. Thank you so much, and God richly bless you, sir.
Thank you very much, Mr. Adams, and your colleague executives. I'm very grateful. So I wish you all the best. And
thank you. Thank you so much. Thank you, Doc.
Thank you very much, Dr. Ajakwa.
Thank you.
I've been privileged to be taught by Dr. Ajakwa at the master's level. So, Doc,
wow.
Thanks so much for the knowledge impacted.
Thank you. Thank you.
All right, Doc.
All right. Bye.
It's a pleasure having you.
Bye. Bye. Thank you. I want to also acknowledge the presence of all our NEC members. And NEC members include the national officers and the regional governors. I want to also acknowledge the presence of Dr. Cosmos Tidoko. I saw him on call, and my very good friend as well, Isaac Owusu Mensah, and all other distinguished personalities who have made time to join this particular call. We are very grateful. The list is very tall. I am unable to go through all. As the days goes, if I see you, I will acknowledge you as such. So before we go, I think some people still have issues with registration. A new link has been posted, and that is what we have been reposting. So please don't go to the earlier one that has been posted. Okay? So make sure that you register through this particular link because that is the only one that will be used to recognize your participation. So kindly take note. I have just posted it again. Everyone should endeavor to register. My boss, Honorable Senam, do you have any announcement to make?
No, Honorable Anas, I don't have any other announcement. I think members can just go back to YouTube and then have a live stream of today's session as well. I keep hammering on that. When the session is over, you can equally go back to YouTube and play from start to finish. So this will be happening till we end this entire CPD training. And subsequent, training programs will be uploaded on our YouTube channel. So I am urging all of us to go onto our YouTube channel, subscribe, like, and share with other members so that when some videos are being shared on that platform, we can go there and then watch it. Thank you very much, Honorable Lanas. That's all I have.
Thank you. Thank you very much. I also see the Dean of the Governors, Honorable Jojo Brown, the Governor of Greater Accra Region. Thank you very much, sir, for joining the call. We are very grateful. And we still entreat all of us to let our colleagues know that the webinar series still continues till Friday. As the President mentioned yesterday, our numbers are far beyond 3,000. But yesterday and today, we registered a little above 400. Sometimes it is very, very challenging if people did not participate in these programs, and at the end of the day, national officers are called upon to add their names for the CPDs to be awarded for the renewals. And as President indicated yesterday, Allied Health is monitoring. Allied Health, they are monitoring. They have access to our link. They join the calls or the meetings unannounced to monitor the numbers that are in the call. And so if the numbers in the call is 400 and you are presenting about 3,000 names for pain renewal, what will happen? And so please let us take note. Regional governors, let us continue to encourage our members in the various regional platforms to continue to do so on the national platform to ensure that all of us take this opportunity so that we can get the CPD points awarded and we'll be able to renew our pains. So if there is no any burning issue, ladies and gentlemen, on this note, I want to say thank you for making time to join today's call. It has been a success as yesterday, and we hope to meet again tomorrow. Tomorrow will be another day where we'll be taking another presentation. And I urge all of us not to miss tomorrow's presentation. On the last day, we shall be discussing issues pertaining to GHIMA and issues pertaining to our welfare at workplaces. And so let us endeavor to ensure that everyone comes on board. People are still calling for registration link. Well, we'll continue to post, even if the meeting closes, the chat box will still be available for you to get the link. We are unable to post the link on the national page because it is not everybody who is in this meeting. And as I said, the AI systems in the Zoom platform is monitoring every member and how long you have stayed on this call. It's monitoring every member and how long you have stayed on this call. So it's not just about the matter of registration. You can just come in, you register, and you go off. Once you go off, the system will indicate that you have not stayed through the meeting for more than 50% of the time spent in the call. And that one will not entitle you to get the day's point. So let us all kindly take note of that. Okay, so once again, thank you very much for joining, and I hope to see all of us tomorrow. Thank you and have a good day.
Yeah, so the meeting is still on. The chat box is still open. So the registration link will be there. It's going to be there active till somewhere around 4:30. So let's keep registering. Those who are late, get on and then register. Thank you.